You're listening to Who Said, a cardiology board review series. No fluff, just facts.
This episode is about ascending aorta dilation and aneurysm. We will go over common terms, epidemiology, intervention, imaging, medical management. Then we will hone in on specific syndromes including Marfan syndrome, Ehlers-Danlos syndrome, Turner syndrome, and Loeys-Dietz syndrome. Let's start. Aortic dilation refers to enlargement of the aorta with dimensions that are greater than expected based on age, sex, and body size, but do not yet meet the threshold for an aneurysm. Aortic aneurysm is permanent dilation of the aorta, typically when the ascending aorta diameter exceeds a certain cutoff, which varies by disease type, which I will specify later on in this episode. Cystic medial degeneration, also known as cystic medial necrosis, is a form of degeneration of the tunica media, the middle layer of the arterial wall. It involves the loss of smooth muscle cells, fragmentation of elastic fibers, and the accumulation of basophilic mucoid material within the media. This weakening of the arterial wall predisposes patients to aneurysms and dissections. The diseases that occur via cystic medial degeneration are aortic aneurysms, especially thoracic aortic aneurysms, which we're covering in this episode, aortic dissection, especially ascending aortic dissections, which we'll cover in the next episode, anything in Marfan syndrome, Ehlers-Danlos syndrome, bicuspid aortic valve, and Loeys-Dietz syndrome, which we'll also cover in this episode, and chronic cocaine use leading to aortic dissection or coronary dissection. These are the diseases that occur via cystic medial degeneration. Let's move on to epidemiology. In terms of the etiology of the thoracic aortic aneurysms, less than 5% are syndromic, even though there's a very heavy emphasis on these on the board exam. These are Marfan, Turner's, Loeys-Dietz, and Ehlers-Danlos. 15 to 20% are familial, which are not the same as syndromic. Familial refers to those arising from mutations in TGFBR2, which is transforming growth factor beta receptor 2, MIH11, which is myosin heavy chain 11, or ACTA2. The rest, which is the majority, are sporadic. Genetic aortopathies, which are the ones caused by mutations in ACTA myosin heavy chain 11 or TGF-beta receptor 2, tend to be diagnosed later than syndromic aortopathies such as Marfan's, since they are phenotypically normal around the time of birth. They tend to be diagnosed around the 5th decade, in the 40s. The level of dilation is not the same for all of them. Dilation can occur at the root or the ascending aorta. Dilation of the root, sometimes called the Marfanoid type, usually occurs in Marfan syndrome, Loeys-Dietz syndrome, and the BAV root phenotype. Dilation of the ascending aorta usually occurs from age, hypertension, atherosclerosis, and BAV other than root phenotype. Extended phenotypes refers to presence of dilation of both the root and the ascending aorta. Dilation of the root is more dangerous than dilation of the ascending aorta. Let's talk about intervention, which is the most important part of the episode because it's the most askable and it's also the one that makes the most difference in terms of patient management clinically. How wide is abnormally wide? First, what's normal? For the ascending aorta, typically 3.5 centimeters and less is considered normal. In most cases, we use centimeters as units for cutoff for defining dilation, but it is different in Turner syndrome, Marfan syndrome, and bicuspid aortic valve. In Turner syndrome, we determine severity by the BSA correction. Severe aorta dilation in Turner syndrome is at least 2.5 centimeters per meter square. In Marfan and bicuspid aortic valve, we use the aortic root cross-sectional area to height ratio. At least 10 centimeters square per meter is associated with worse outcomes. According to the 2022 AHA-ACC guidelines for aortic disease, the cutoffs for surgical intervention for dilation of the aortic root or ascending thoracic aorta are 5.5 centimeters for sporadic aneurysms and bicuspid aortic valve associated aneurysms, 5.0 centimeters for Marfan syndrome, and 4.0 or 4.5 for different types of Loeys-Dietz syndromes. Let's hone in on each of these. The 5.5 centimeter cutoff is the one for most of the cases, sporadic aneurysms, which makes up approximately 3/4 of all cases, as well as bicuspid aortic valve, BAV, associated aneurysms. Surgery can be considered early for these people at an ascending aortic diameter of 5.0 to 5.5 centimeters if there are additional risk factors for aortic dissection, such as family history of dissection or a high rate of growth exceeding 0.5 centimeters per year. Early surgery at 5.0 to 5.5 centimeters can also be considered if those risk factors for aortic dissection are not present, but if it is being done by an experienced surgeon in a multidisciplinary aortic team. The threshold may be adjusted based on patient genetics, rapid growth rate, cross-sectional area to height ratio of at least 10 centimeters square in the case of Marfan and bicuspid aortic valve, aortic size index of at least 3.08 centimeters per meter square, or aortic height index of at least 3.21 centimeters per meter. So that's for sporadic aneurysms and bicuspid aortic valve associated aneurysms, where the cutoff is 5.5 centimeters and it can be brought down to 5.0 for early intervention if there's a high growth rate of at least 0.5 centimeters per year, or family history of dissection, or it is being done at an experienced surgical center. Now for Marfan syndrome, the cutoff is 5.0 centimeters for intervening. The cutoff for Marfan syndrome can be brought down to 4.5 centimeters if it is being done by experienced surgeons in a multidisciplinary aortic team. For Loeys-Dietz syndrome, the cutoff is at either 4.0 or 4.5 centimeters. If the genetic variant is in TGF-beta receptor 1 or 2 and there are no high-risk features for dissection, then the threshold for prophylactic aortic root and ascending aorta replacement is at least 4.5 centimeters. If the genetic variant is TGF-beta receptor 1 or 2 and there are high-risk features for dissection, then the threshold moves up early to at least 4.0 centimeters. If the genetic variant is in SMAD3 or TGF-beta 2, not TGF-beta receptor 2, then the threshold is 4.5 centimeters or higher, regardless of risk factors. If the genetic variant is TGF-beta 3, then the threshold is at least 5.0 centimeters, regardless of risk factors. In non-syndromic conditions, the cutoff, which was 5.5 for sporadic aneurysms, can be lowered to 4.5 centimeters if there is a separate surgical indication for aortic valve replacement. Rapid aortic growth or ascending aortic aneurysm growth, an indication for intervention early, is defined as more than 0.5 centimeters in 1 year or more than 0.3 centimeters per year in 2 consecutive years for those with sporadic aneurysms, and more than 0.3 centimeters in 1 year for those with heritable thoracic aortic disease or bicuspid aortic valve. Let's hear the exact wording from the 2022 guidelines about surgical or transcatheter management of ascending aorta dilation and aneurysm. According to the guidelines, in patients with aneurysm of the aortic root and ascending aorta who have symptoms attributable to aneurysm, surgery is indicated. That's a class 1 recommendation. In asymptomatic patients with aneurysms of the aortic root or ascending aorta who have a maximum diameter of at least 5.5 centimeters, surgery is indicated, class 1. So that is that 5.5 that we talked about for the general case for people with sporadic aneurysms. Next, in patients with an aneurysm of the aortic root or ascending aorta less than 5.5 centimeter, whose growth rate confirmed by tomographic testing is at least 0.3 centimeters per year in 2 consecutive years, or at least 0.5 centimeters in 1 year, surgery is indicated, class 1. So this is exactly what we said in terms of the definition for rapid growth. Next, in asymptomatic patients with aneurysms of the aortic root or ascending aorta who have a maximum diameter of at least 5.0 centimeters, surgery is reasonable when performed by experienced surgeons in a multidisciplinary aortic team, class 2A. So this is the situation where for the general case, the 5.5 is being brought forward to 5.0 if you have an experienced team. In patients undergoing repair or replacement of a tricuspid aortic valve, who have a concomitant aneurysm of the ascending aorta with a maximum diameter of 5.0 centimeters or more, ascending aortic replacement is reasonable, class 2A. It is reasonable to replace at least 4.5 centimeters or more when performed by experienced surgeons in a multidisciplinary aortic team, class 2A. Next, in patients undergoing cardiac surgery for indications other than aortic valve repair or replacement, who have a concomitant aneurysm of the ascending aorta with a maximum diameter of at least 5.0 centimeters, ascending aortic replacement may be reasonable, class 2B. So this is very similar to the last statement that I read to you, except now this one is a class 2B instead of class 2A recommendation. Next, in patients with a height more than one standard deviation above or below the mean who have an asymptomatic aneurysm of the aortic root or ascending aorta and a maximal cross-sectional aortic area to height ratio of at least 10 centimeters square per meter, surgery is reasonable when performed by experienced surgeons in a multidisciplinary aortic team, class 2A. In asymptomatic patients with aneurysms of the aortic root or ascending aorta who have either an ASI of at least 3.808 centimeters per meter square or an AHI of at least 3.21 centimeters per meter, surgery may be reasonable when performed by experienced surgeons and a multidisciplinary aortic team, class 2B. Next, let's move on to imaging. Now that we have these cutoffs pat down. What exactly are you measuring? The thoracic aorta consists of the aortic root, ascending aorta, aortic arch, and descending aorta. The sinotubular junction and sinuses of Valsalva are measured leading edge to leading edge in end-diastole when you are performing echocardiography, whether this is TTE or TEE. The aorto-ventricular junction, aortic annulus, and LV outflow tract, which is by definition 5 to 10 millimeters from aortic annulus in some textbooks or at the base of aortic leaflets and other textbooks, those are measured inner edge to inner edge in mid-systole on echo. So you have to not confuse those two, okay? Leading edge to leading edge is sinotubular junction and sinuses of Valsalva on echo, whereas inner edge to inner edge in mid-systole is aorto-ventricular junction, aortic annulus, and LV outflow tract. The practice of measuring leading edge to leading edge on echo began because in the early days of ultrasound, the aortic root was measured in M mode, and the interface of the leading edge was easier to delineate than the inner edge. Today, in 2D echo, it is possible to accurately measure structures without needing to rely on the bright interface of the leading edge to guide caliper placement, but the reference nomograms have been established using leading edge to leading edge convention. Meanwhile, CT and MRI have moved on to the modern method of inner edge to inner edge. In terms of imaging modality, echocardiogram is adequate for assessing ascending aorta dilation progression if there is visualization of the aorta up to 4 centimeters distal to the valve. CT or MRI will provide better spatial resolution and is preferred if the patient has poor echo windows. Conversely, patients with CT findings of dilation of the aortic root or ascending thoracic aorta should be evaluated for bicuspid aortic valve and or aortic regurgitation with an echo, so you get an idea of any aortic valve disease present before you do surveillance CT for growth in aortic root or ascending aorta diameter. Bicuspid aortic valves are frequently associated with aorta dilation either at the level of the sinuses of Valsalva or more frequently at the ascending aorta. The incidence of aortic dilation is higher in patients with fusion of the right and left coronary cusps. As I said just now, if a patient is found to have dilation of the aortic root or ascending thoracic aorta on CT, for example, done for PE or other indication, and has not had an echo yet, they need to get an echo to evaluate for bicuspid aortic valve and or aortic regurgitation, since the co-occurrence of a bicuspid aortic valve or AR with aortic dilation of the sinuses of Valsalva or ascending aorta is high. Aortic imaging with CT angiography or MRI or MR angiography is recommended for all first-degree relatives of patients with bicuspid aortic valves, especially when there is a family history of thoracic aortic aneurysm and or aortopathy. Several genetic conditions are associated with the development of thoracic aortic aneurysms, including Marfan syndrome, Loeys-Dietz syndrome, Turner syndrome, bicuspid aortic valve disease, and familial thoracic aortic aneurysm disease. First-degree relatives of affected individuals should be screened. Epi-aortic echocardiography is superior to TEE for detecting aortic atheroma in the distal ascending aorta and aortic arch due to the interposition of the air-filled trachea and bronchus, which can cause a blind spot in these segments of the aorta when using TEE. So TEE is not always superior. TTE is first line, but cardiac MRI or CT may be indicated if the morphology of the aortic sinuses, sinotubular junction, and ascending aorta cannot be adequately visualized on TTE. So that's imaging modality to choose. How often should you be doing the imaging? Generally, yearly aortic imaging to monitor ascending aortic dilation can be done by echo if there's adequate image quality with visualization of the aorta up to 4 centimeters distal to the valve. Alternatively, CT or MRI can provide better spatial resolution and is preferred in patients with poor echo windows, although the CT, of course, comes with a radiation cost. In patients with Marfan syndrome, TTE should be done at the time of initial diagnosis to determine the diameters of the aortic root and ascending aorta, and 6 months thereafter to determine the rate of aortic growth. If the aortic diameters are stable, then an annual surveillance TTE is recommended. In non-Marfan patients, once you have an ascending aortic aneurysm more than 4.5 centimeters, only then do you need to do yearly imaging of the aneurysm. Next, let's move on to medical management. What is the medical management for ascending aorta dilation and aneurysm? According to the 2022 AHA-ACC guideline for the diagnosis and management of aortic disease, in patients with thoracic aortic aneurysm and an average systolic blood pressure of at least 130 millimeters of mercury or an average diastolic blood pressure of at least 80 millimeters of mercury or more, the use of antihypertensive medications is recommended to reduce the risk of cardiovascular events, Class 1. In patients with thoracic aortic aneurysm, regardless of cause and in the absence of contraindications, use of beta blockers to achieve target blood pressure goals is reasonable, Class 2A. In patients with thoracic aortic aneurysm, regardless of etiology and in the absence of contraindications, ARB therapy, angiotensin receptor blocker therapy, is a reasonable adjunct to beta blocker therapy to achieve target blood pressure goals, Class 2A. In other words, they want you to use beta blocker plus or minus ARB to get the systolic blood pressure down to 130 or less. In patients with thoracic aortic aneurysm and imaging or clinical evidence of atherosclerosis, statin therapy at moderate or high intensity is reasonable, Class 2A. In patients with thoracic aortic aneurysm who have no evidence of atherosclerosis, the use of statin therapy may be considered, Class 2B. In patients with thoracic aortic aneurysm who smoke cigarettes, smoking cessation efforts are recommended, Class 1. Now, we will spend time going over the specific syndromes strongly associated with ascending aorta dilation and aneurysm: Marfan syndrome, Turner syndrome, and we'll end with Loeys-Dietz syndrome. Signs and symptoms of Marfan syndrome other than aortic root dilation are myopia, which is severe nearsightedness due to ectopia lentis, mitral valve prolapse. Either pectus carinatum or pectus excavatum are possible. Pectus carinatum, also known as pigeon chest, is when the sternum protrudes outward, giving the chest a bowed-out appearance. Pectus excavatum, also known as funnel chest, is when the sternum is sunken inward, giving the chest a caved-in appearance. There will also be arachnodactyly with wrist and thumb signs, and scoliosis or thoracolumbar kyphosis. Arachnodactyly in Marfan syndrome refers to abnormally long and slender fingers. The thumb sign in Marfan syndrome is when the patient makes a fist over the clenched thumb and the thumb extends significantly beyond the ulnar margin of the hand. The wrist sign in Marfan syndrome is when the thumb overlaps the fifth finger when one hand is grasping the contralateral wrist. Fibrillin 1 is the gene mutated in 90% of cases of Marfan syndrome. Ehlers syndrome is quite similar to Marfan syndrome, so you need to know how to distinguish Ehlers syndrome from Marfan. You can distinguish them based on slightly different characteristics in their skin manifestations, musculoskeletal, cardiac, eye, and genetics. In terms of skin, Ehlers-Danlos is the only one with easy bruising, poor healing, transparent skin, and velvety skin with atrophy and scarring. Marfan syndrome should have no major skin findings other than striae. In terms of musculoskeletal, joint hypermobility and scoliosis is shared by both Ehlers-Danlos and Marfan. Ehlers-Danlos will have pectus excavatum, whereas Marfan syndrome can have pectus carinatum or pectus excavatum. Disproportionately tall stature and long extremities with increased arm span to height ratio is Marfan syndrome, not Ehlers-Danlos. Ehlers-Danlos has joint dislocations and premature degenerative joint disease, which Marfan doesn't have. Ehlers-Danlos has a high arch palate. Next is cardiac. Marfan's has aortic root dilation leading to aortic dissection. While Marfan's has aortic dissection, Ehlers-Danlos has berry aneurysm in the brain. Mitral valve prolapse can occur in either Ehlers-Danlos or Marfan syndrome. Marfan has a mitral valve prolapse in 70% of patients, with 1/4 progressing to severe mitral regurgitation. Marfan's has upward lens dislocation, whereas Ehlers-Danlos has no lens dislocation. Ehlers-Danlos has development of abdominal and inguinal hernias and cervical insufficiency and uterine prolapse. Marfan's has spontaneous pneumothorax. In terms of genetics, Ehlers-Danlos is from a collagen 5A1 and 5A2 gene mutation, whereas Marfan is from a fibrillin 1 gene mutation. There's some special considerations in terms of the management of thoracic aortic aneurysm and dilation in Marfan syndrome specifically. Marfan syndrome patients are at high risk of aortic dissection, occurring in 1% of Marfan syndrome women with aortic diameter less than 4.0 centimeters, and as much as 10% in Marfan syndrome patients with high-risk features such as aortic diameter more than 4.0 centimeters, rapid dilation, or previous dissection of the ascending aorta. In most women with Marfan syndrome, aortic dissection occurs during the 3rd trimester or postpartum, although it may occur at any time. In women with Marfan syndrome wanting to get pregnant but having an aortic diameter more than 4.0 centimeters, it is reasonable to consider prophylactically replacing the aorta prior to pregnancy. Pregnancy is contraindicated in Marfan syndrome patients with a dilated aorta more than 4.5. The aortic dissection of Marfan syndrome usually starts just above the coronary ostia and may extend into the entire length of the aorta. Beta blockers should be started on all Marfan syndrome patients unless a contraindication exists, because beta blockers limit aortic shear stress and can slow the rate of aortic root dilation. ARB should also be started on all Marfan syndrome patients unless a contraindication exists, because ARBs slow progression of aortic enlargement via modulating TGF-beta signaling. To reduce progression of aortic root dilation in Marfan syndromes, you need to also aggressively control the hypertension. Remember that in Marfan syndrome, the threshold for surgical repair of aortic aneurysm is lower than that in the general case. You must avoid fluoroquinolones and calcium channel blockers such as amlodipine because they worsen the expansion of ascending aortic aneurysm. Now, let's move on to Turner syndrome. Turner syndrome has shield chest with widespread nipples, webbed neck, low posterior hairline, gonadal dysgenesis leading to primary amenorrhea and lack of secondary sex characteristics and infertility, short stature, and nevi. Only women are affected by Turner syndrome, whereas Noonan syndrome can occur in men or women. What do the guidelines say for Turner syndrome? According to the 2022 AHA-ACC guideline for the diagnosis and management of aortic disease, in patients with Turner syndrome, TTE and cardiac MRI are recommended at the time of diagnosis to evaluate for bicuspid aortic valve, aortic root, and ascending aortic dilation, aortic coarctation, and other congenital heart defects, class 1. In adults with Turner syndrome, the use of ASI, the ratio of aortic diameter in centimeters to the BSA in meters square, is recommended to define the degree of aortic dilation and assess the risk of aortic dissection, class 1. In patients with Turner syndrome without risk factors for aortic dissection, surveillance imaging with TTE or MRI to evaluate the aorta is recommended every 5 years in children and every 10 years in adults, as well as before planning a pregnancy, class 1. In patients with Turner syndrome and an ASI more than 2.3 centimeters per meter square, surveillance imaging of the aorta is recommended at least annually, class 1. In patients with Turner syndrome who are at least 15 years old and have an ASI of at least 2.5 centimeters per meter square, plus risk factors for aortic dissection, surgical intervention to replace the aortic root, ascending aorta, or both is reasonable, class 2A. In those without risk factors for aortic dissection, surgical intervention to replace the aortic root, ascending aorta, or both may be considered, class 2B. Now let's move on to Loeys-Dietz syndrome, our last syndrome in this episode. Loeys-Dietz syndrome presents as a 25-year-old male with foot pain and multiple food allergies. Unlike Marfan syndrome, whose vascular dilation only occurs at the level of the ascending aorta, Loeys-Dietz syndrome can cause dilation anywhere, such as the superior mesenteric artery that can dilate or the vertebral artery that can dilate. So Loeys-Dietz needs annual surveillance of the entire vasculature, MRI or CT from head to pelvis initially, then chest to pelvis thereafter. A bifid uvula characteristically suggests Loeys-Dietz syndrome. Features of Loeys-Dietz syndrome other than foot pain, multiple allergies, and bifid uvula are hypercalcemia, microcephaly, depressed nasal bridge and broad forehead, intellectual disability, supravalvular aortic stenosis, cleft palate, and pectus excavatum. High-risk features for dissection in Loeys-Dietz syndrome are women who have a TGF-beta receptor 2 mutation and small body size, severe extra-aortic features such as craniosynostosis, cleft palate, hypertelorism, bifid uvula, marked arterial tortuosity, widened scars, and translucent skin, family history of aortic dissection, especially at a young age or relatively small aortic diameter, or aortic growth rate more than 0.3 centimeters per year inclusive. What did the guidelines say for Loeys-Dietz syndrome? According to the 2022 AHA-ACC guideline for the diagnosis and management of aortic disease, regarding imaging, in patients with Loeys-Dietz syndrome, a baseline TTE is recommended to determine the diameters of the aortic root and ascending aorta, and 6 months thereafter to determine the rate of aortic growth. If the diameters are stable, then annual surveillance echo is recommended, class 1. In patients with Loeys-Dietz syndrome and a dilated or dissected aorta and/or arterial branches at baseline, annual surveillance imaging of the affected aorta and arteries with MRI or CT is recommended, class 1. In patients with Loeys-Dietz syndrome, a baseline MRI or CT from head to pelvis is recommended to evaluate the entire aorta and its branches for aneurysm, dissection, and tortuosity, class 1. In patients with Loeys-Dietz syndrome without dilation of the aorta distal to the aortic root or ascending aorta and without dilated or dissected arterial branches, surveillance imaging from chest to pelvis with MRI or CT every 2 years is reasonable, but imaging may be more frequent depending on family history, class 2A. Then, in patients with Loeys-Dietz syndrome without dilation of the cerebral arteries on initial screening, periodic imaging surveillance for cerebral aneurysms with MRI or CT every 2 or 3 years is reasonable, class 2A. For medical treatment, they say, in patients with Loeys-Dietz syndrome, treatment with a beta blocker or an ARB unless contraindicated or both in maximally tolerated doses is reasonable. So far, in every syndrome that we've encountered in this episode, as well as the general sporadic case of thoracic ascending aorta dilation or aneurysm, they want you to put in a beta blocker and an ARB unless contraindicated. Then for surgery, the guideline says in patients with Loeys-Dietz syndrome attributable to a pathogenic variant in TGF-beta receptor 1, 2, or SMAD3, surgery to replace the intact aortic arch, descending aorta, or abdominal aorta at a diameter of at least 4.5 centimeters or more may be considered with a specific genetic variant, patient age, aortic growth rate, family history, presence of high-risk features, and surgical risk informing the decision. TGF-beta 3 is replaced when aorta diameter reaches 5.0 centimeter or more, class 2B. TGF-beta 2, class 2B, and SMAD3, class 2A, are replaced when the aorta diameter reaches 4.5 centimeters or more. TGF-beta receptor 1 and 2 are replaced when the aorta diameter reaches 4.5 centimeters, class 1, or 4.0 centimeters, class 2B and 2A, respectively. That was a very, very long and detailed and dense episode because the guidelines differ just so slightly for Marfan syndrome, Turner syndrome, Loeys-Dietz syndrome, and the sporadic case of TAA. Congratulations on getting through all of this. The next episode will be much easier, I promise.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.